Great. Welcome, everyone. Tonight, I'm really excited. We get to talk about something that we don't really talk often about, which I think is a disservice. We're going to talk about um, physical therapy today. So I'm really excited that we have Dr. Patricia Meegan, Dr. Trish, here with us today. So I know you are particularly interested in Ehlers Danlos and Chiari, things like that. So I just want to first, what's going to happen is I'm going to have you introduce yourself, maybe talk a little bit about why you're interested in Chiari and EDS related disorders, what got you interested in this stuff. And then I'm going to also make you the presenter so that you can share your slides. But
Okay.
first, let me do that first, I guess. That makes it easier. Here we go. Presenter. Just let me know how that goes. See? In the meantime, I just want to thank everyone for joining us tonight. I know this is going to be a good one. So, okay, so you have that. I'm actually going to disappear for a bit while you introduce yourself, talk about why you're interested, and go through your presentation. Then I'll come back for questions.
Okay. So my name's Trish. For those of you who don't know me, I saw a bunch of people that do know me. I was like, watched all of you come in. So I'm a physical therapist and an athletic trainer, and I'm in Rhode Island. I would say 75 to 90% of my caseload is patients with Ehlers Danlos, Chiari, tethered cord, and complex medical issues. So I treat very differently than your probably standard physical therapist. I am more osteopathically trained, so we do a lot of manual therapy in our clinic. So I guess the way that I sort of got interested in all these conditions was they showed up on my doorstep. So back in, I think, 2012, we had the National EDS conference here in Rhode Island, and I was part of that conference, and we were speaking, and some of the therapists that I know were speaking and answering questions for patients, and all of a sudden, a week later, our clinic flooded with patients with EDS and like-minded conditions. And since then, we already had a bunch, and it's just now been propagated of, how to treat this, therefore, you're going to see more of it. And the more that I saw, the more that I learned. And pretty much everything I've learned from the patients that I've had, but also connecting with all of the people, because we tend to, as you all know, we tend to share the same population. So all of my patients see the same doctors, all the experts that are in this area. We all talk to each other and we all know each other. So I got invited to my first Bobby Jones CSF think tank quite a few years ago with Dr. Henderson, and ever since then I've been really involved with the organization there. And now, because of telehealth, unfortunately, we don't always get to see patients, but I see patients from all over the country, all over the world, often just virtually, but then a lot of patients will come and arrive and get therapy because it's a different type of therapy than many people have experienced in the past. And that's kind of what we're going to talk about today, is how the unique type of PT we work on is actually very, very effective for this patient population, and how it can make a big difference going forward. So that's about it. I think that was about everything I teach at different levels. I think it was all in my bio. But I guess we'll just go through the presentation because I think Caitlin said to start that after.
Yep, you got it. That was perfect. Thank you.
Okay. I didn't know if I was waiting for you to come back.
No.
So today we're going to focus on manual therapy for the head with a focus on the proper alignment of the head and neck. It's a physical therapy is a big, broad topic, so I tried to very much narrow it down to this specific patient population and a very specific region and type of therapy. I can't move my slides. What happened? I did it yesterday. There we go. Okay. Standard disclosures and disclaimers. I'm on the board of directors for the Dysautonomia Support Network, but there's nothing financial. There's no conflicts in this presentation. Definitely this discussion, especially with the question and answer for this discussion and presentation, are for general purposes only. I do not and will not answer any personal medical questions in this forum, and I won't give any medical or physical therapy advice over the internet to people in a conference. Pictures of everybody in here are patients or friends who have given their expressed concerns, and there's no HIPAA violations. So the objective for what we're going to cover today is basically what do PTs treat? Pretty much trying to also change the perspective and outlook on what PT is, because I think oftentimes physical therapy gets a bad rap from having lots of negative experiences. All of my patients come in telling me that they hate PT pretty much off the bat when I meet them. So it's always a battle that we're coming up against. But I also want to discuss the difference between structural and functional physical therapy, and then focus on the biomechanics of the cranial cervical junction, obviously the head and neck, which is kind of what we're focused on. And then very importantly, I'd like to add into this lecture how to go about choosing a PT, and then when you should lose the PT that you're working with, because you don't always have to be with the same person. So my goal for this presentation, if nothing else, is to change the perspective of change the perspective of what physical therapy can do for this patient population, and that PT is not just about exercise. That PT extends far beyond muscles and joints, and that physical therapists treat connective tissue, and don't pigeonhole your PT experience into just treating, the muscles and the joints and the bones. So physical therapists treat
I'm so sorry, Dr. Meegan, the PowerPoint isn't sharing anymore.
Oh, hold on. Is that better?
Yeah, it's in, oh, there you go. Yep. Perfect.
Does that make sense?
Yep, got it.
Okay. So physical therapists treat somatic or body dysfunctions, and then in relation, they treat the impaired and altered function of the related components of the somatic or body system. PTs are primarily known as a general sense to treat mild fascial and skeletal tissues, like we talked about the muscles and the bones, but we're also licensed and trained to treat all of the related vascular, lymphatic, and neural components. So Chiari being a very neurally based dysfunction, it falls under the purview of PTs, even though most of the time many people will tell you that we can't treat it or we don't know what we're doing. And many patients have many PTs have never encountered this. So what makes my experience different is I was trained more as an osteopathic manual therapist, so I have a very different background. I went to undergrad, had athletic training, sports medicine, physical therapy, doctorate, but I also at the same time was training with an osteopathic clinic. So I was trained more in a manual therapy field that's very different than standard manual PT for clinics. And then so this lecture in particular, we were going to have a targeted discussion of the head and neck in terms of osteopathic, with a focus on the Chiari malformation and the overlapping symptoms with the other comorbid conditions. But it's very important that I always make sure patients know that I don't treat Chiari, because that's not my job. Like I said, I'm a physical therapist, and we treat connective tissue. So I do not treat Chiari per se. So I never treat Chiari. I treat patients who happen to have Chiari. So I saw one question already pop up about what is osteopathic. So osteopathic versus allopathic. So if you think about the medical profession, an osteopath is somebody that has the initials DO, and an allopath is somebody that has the initials MD. The same thing is kind of true with PT. So osteopathic is more of a structural rehabilitation model. It's looking at an osteopathic model, which is a recovery-based model, focused on treating the root cause of the dysfunction, whereas the functional rehabilitation model is more of an allopathic. It's a disease-centered model where you treat the compensation. It's a compensation-based model. So if you, for example, have a limp, the PT would give you a cane. Or in this situation, if you have, again, not a very broad statement, but if you had cranial cervical instability, or any sort of instability, we'd give you a brace and call it quits, because the brace is the compensation, whereas the structural rehabilitation would be correcting the structural alignment and issues around it so you wouldn't need the brace. So some examples of structural manual therapy techniques are muscle energy, myofascial relief, strain counter strain, cranial therapy, which is cranial osteopathy, cranial sacral therapy, and visceral manipulation or mobilization. So the presentation will be made, public later for you guys to watch, but this is a good slide to write down when I come to the kind of how do you choose a PT. These are the key words that you should know going forward, and I'm not going to explain what every type of technique is. It's not the point of this lecture, but these are all the techniques I use with every single patient that I see almost every time they come in. So if you have a patient, if you have a PT that says, oh, I'm a cranial sacral therapist, that's not good enough. Or I know how to do muscle energy. Well, that's not good enough. You need to have somebody that can do all of these techniques. And if you can get somebody who's well versed in these techniques, then they can call themselves a manual therapist. But if somebody went to a conference for a continuing education one weekend and they took one course and they, now consider themselves a manual therapist, you're really not getting a good breadth of knowledge from that person. Functional therapy is balance, proprioceptive training, neuromuscular reeducation, vestibular rehab, postural education, stability strengthening, and gait training and cardio. Again, you can't have one without the other. These are all incorporated into every session that I have. And you have to do both. You can't just be one or the other. You can't just do functional and you can't just do structural. You have to do a combination of both of them. So in the osteopathic world, they say structure governs function and function influences structure. So I like this picture because a nail has a very specific function. It should be straight and it's hit with a hammer and it joins things together. But if your nail is crooked and you still try to hit it with a hammer, it's not going to go in straight. It's not going to do its function. But that doesn't mean that you need to throw the nail away and use something else. You don't need to change your apparatus and get a screw or a different compensation. All you need to do is use your hammer and kind of bang the nail out until it's straight, and then it can redo its function. But if you're trying to ask it to do its function while it's crooked, it's not going to. So one of the techniques was myofascial release. So it's important to know what fascia is. So fascia is very important. So it's pretty much what PTs treat without a lot of times explaining that to patients. Fascia is a highly complex web of connective tissue. It's basically the fabric that holds the body together. It's one continuous piece of tissue that goes from the tip of your toes all the way up to the top of your head, and it's separated into three generalized categories. It's separated into superficial fascia, deep investing fascia, and visceral fascia. They all have different structures. They all have different functions. They all work together. So it's important. I put the stars next to the deep investing fascia because we're going to talk about that very specifically with a type of technique that's related to Chiari and how this PTs treat fascia, PTs treat connective tissue, and then there's a very specific deep investing fascia that will relate to a Chiari treatment. So in general, how this works and how fascial work and manual therapy works, my little cylinder there, we'll call it a muscle for argument's sake, but that's the area that we're treating. That's the part of the body, that's the soma. And then the gray part is the cross-section of the spinal cord. So the way that works is we call it a facilitated segment. We have information that goes from the area of your body into the spinal cord. That's called sensory or afferent information. And then it sends it from the spinal cord back out to the body or the muscle in efferent or motor information. So you get sensory information to go into your spinal cord gives it a signal, and it sends motor input back out, and that's how the body functions. When there's some sort of injury to that area, it sends out increased information saying, we'll use example, you have a tear in your bicep muscle in your arm. That muscle sends out extrasensory info saying, I think there's a problem here. It sends out the sensory info saying, ow, it really hurts. So then the body, the spinal cord sends out more information, says, well, you must be injured, so let's shorten you because that's the best thing you should do. We'll make it shorter and it'll take that injury away. But we all know that when we shorten a muscle that's already injured and it cramps, it causes more pain on that. So it starts to spasm and it sends out more information. Then it says, well, I'm still hurt. And then it says, okay, well, then still shorten, and it still spasms and cramps up more. And it's this cycle that doesn't stop. This is where PT comes in. You need to break that cycle. However, we get in these chronic conditions where this continues to happen, and if you don't do something about it, your body says, well, if you're not going to do anything, I'm going to start to send the information to more important places. And if you won't listen to the pain that you have in your arm, I'm going to send it to your heart or your brain or your organs or your kidneys, and I'm going to start to shut them down and give them extra information, because maybe if you start to have heart symptoms, you'll pay attention and you'll do something as opposed to this muscle that you're really ignoring. So whether it's your heart or something else, that's how this goes. This is where the overlap to, muscular, skeletal issues, and then the Chiari in the brain, there's a cross between. So it can go from the muscle into coming feedback getting sent to the organ, or the organs can say, I'm really struggling here. There's something wrong. And if you can't identify those symptoms, then it sends it out to other areas, like when you have a heart attack and you have arm pain, or when you have Chiari and you start to get arm pain, neck pain, and all the other symptoms. Your brain is sending the information out to the body to be interpreted so that you'll pay attention. So at the cranial cervical junction, we have the skeletal structures, which are labeled here. Basically, we have your occiput, which is the basin of your skull, and then we have your atlas and axis joints of C1 and 2. And so the atlas is your C1, and that's the vertebrae that holds up your head. So we're talking very specifically about the mechanics of the cranial cervical junction, which is the OA joint, the occipital atlanteal joint. And if you look on the other side where it says myofascial tissue, I just want you to really take note of all of the junk that's in there. It's a very complicated area. It's very crowded, and there's a whole lot of muscles. All of the red things are muscles. All the red big structures are muscles. The yellow lines are all nerves. And all of that white tissue, that's all fascial tissue. That's very, very thick, connected tissue. So all of that is jammed up in that little area too. So this is what we treat. But when you have a patient with a Chiari dysfunction, you got to remember that underneath all of that same area that we were just looking at, there's a lot of really important stuff there. That's your brainstem, your cerebellum, your brain, your spinal cord. That whole area that we just tend to think of as muscles and joints is brain tissue and neural tissue and fluid. And it's important that you respect that that's there, because you can have some powerful impacts on it. The OA junction, so that's what we're going to talk about, the biomechanics. It's made up of occipital condyles, which I call the knuckles of the skull, and they're convex condyles on what we call concave facet. So you can see there, the facet is the joint of the C1, so those are concave, and the joint of the skull is convex. So the knuckle sits in a little groove on the top of the vertebrae. So this allows for side bending and rotation to occur in opposite directions. So basically, in neutral, the head sits straight. With the mechanics of the skull, you can have side bending to the right with rotation to the left, or side bending to the left with rotation to the right. That's what happens when the skull moves. So all other motions, any sort of rotation that's different than that is coming from the neck, not the skull. But what's important to note is that the brain is going to attempt to keep your eyes level with a horizon line so that you don't notice that you're looking crooked. So if you look at the picture where they're side bent to the right and rotated to the left, his eyes are visually going to occur so that he thinks that he's neutral. So then other areas of his body is going to start to accommodate and change so that as his head tilts, he's not going to look crooked. His whole body is going to shift so that his head tilts, his whole body will adjust so that his eyes stays correct to the horizon line. The spine biomechanics are important to know. So the spine underneath the skull with the cervical spine has very specific motions as well. And those joints are called facet joints. They're the ones that create the motion through the spine, and they can get locked up just the same way that we talked about the skull getting locked up in those positions. And so when those joints get locked, that's what we call the facilitated segment. So that's what we're treating with PT, is that facilitated segment. I'm not going to go through all of the symptoms. I think everybody here is here because they understand and know what Chiari is, but Chiari symptoms are broad in their general sense. So a lot of times they're misdiagnosed, but they're very important to recognize that as you're treating the head and neck, the symptoms of Chiari will cross over with other dysfunctions as well. So it's important to really communicate what symptoms you're feeling with your PT, because your neck pain might be from your Chiari, your neck pain might be from your neck. So it's really important that you communicate what you're feeling, because the type of pain that you're feeling might be different. So some people have been asking questions in the chat box, but just feel free, if I'm saying something and it doesn't make sense to you, I can see them as they pop up, so I can try and address them a little bit more clearly as I'm speaking, but use the chat box and fill up your questions there, because for the question and answer afterwards, we can go through all of those as well. So if I'm not explaining something that you want now, if I can see it quickly, I might be able to explain or reword what I'm saying. So the dural system. So your dura is the protective coating around your brain and spinal cord. Your dura is made up of that deep investing fascia that we talked about earlier. So your dural system is what we call, in an osteopathic world, the way that we explain it, it's called a reciprocal tension membrane. Now, I don't expect anybody here to even have ever heard this, and I don't expect most of the PTs out there to know what this is. So the dural system that we're talking about, it's made up of your falx and your tentorum, which are the components that divide up the brain and hold the brain in place. So basically, it's the part that holds the brain from whacking itself from left to right. And the falx tentorum, tentorum cerebri is the part that keeps the top of your brain from whacking into the bottom of your brain every time you jump around and move. These are very strongly attached into different bones of your cranium inside of your skull, to different little nooks and grooves, but they are also attached directly around the entire foramen magnum, which is the hole at the base of your skull that a Chiari slips through. They're also attached in the front of C2 and C3 of the cervical spine, and then they're also attached at S2. So this is the science behind when patients, or when PTs say that they're doing cranial sacral work and they have a hand on your head and a hand on your sacrum, and you don't know why they're doing what they're doing. This is it's a very mechanical, scientific, medical link of why they're treating both ends of the system and how the system does move. So the dural system, just like your heart has a beat, your brain has a beat. Your brain and your nervous system has a beat, and it can be felt if you know how to treat through that neurological dural system, which is not very common and most people cannot do. And to be perfectly honest, most doctors will tell you that we're crazy unless they've experienced it before. Most of the doctors that I work with now know that I'm a little crazy, and we've had these discussions, and they all know what I do and what I treat. So I think that's important to know is there is a science behind what we're doing, but this is how. So I don't treat Chiari malformations. I don't treat Chiari. I treat the connective tissues that surround the Chiari and affect the cranial cervical junction. And this is the picture that I kind of think shows the best representation of that. Another thing we're going to talk about is dysautonomia. So dysautonomia, a lot of the symptoms of Chiari are also dysautonomia symptoms, because dysautonomia is just a blanket term for malfunction of the autonomic nervous system. The autonomic nervous system is that automatic system that controls your brain and your body. It's not your brain. It's not your spinal cord. It's the system that controls all of the automatic functions in your body, and it affects everything in your body. It affects every single system of your body. And since we already discussed that connective tissue exists in every single system of your body, you can have an effect on dysautonomia and dysautonomia symptoms with physical therapy by treating different areas of the body. So I've kept the pictures in here from a different lecture because I think the pictures do a better job in this area of the clinical correlation. So with patients that have Chiari that also have connective tissue disorders, this makes a little bit more sense. But so if you look at the system, the autonomic nervous system is divided into two parts. So the sympathetic division is those fight or flight reflexes, and then the parasympathetic division are those rest and digest. So the rest and digest reflexes are, let me go back to that one, sorry. The parasympathetic system are those rest and digest, and those are your cranial sacral reflexes. So that's why cranial sacral therapy exists as a modality. So they're located in your cranium or your brainstem, and then down in your sacral plexus, and then your sympathetic system, those fight or flight reflexes are located through your thoracic and lumbar spine, which is what this is a picture of. So this is a picture of your thoracic spine with the rib cage. So the sympathetic ganglion of those nerves are located directly in front of the rib. So when there's a rib subluxation or there's a small issue with the joint in the thoracic spine and it causes a pinching or compression of the nerve through the autonomic system, it causes an autonomic reaction, which is then going to set off a cascade of symptoms, and that will cause what we call a somatovisceral dysfunction. So somato, like we talked about, was body, and visceral means organ. So this is where we allow, this is where you get the crossover of those symptoms that kind of don't make a lot of sense and aren't really muscular or joint symptoms that play into PT. So when you treat the underlying cause, so when you treat the rib subluxation, or you treat in our situation, you treat the alignment of the head and neck that's causing the compression on the brain in any extra compression that wouldn't have already been caused from the Chiari. But if you treat the compression of that area, you alleviate the pressure on those nerves, you can alleviate the overarching dysautonomia symptoms, which can be some of the more suffering symptoms for patients with Chiari. So this is how we're going to talk about the head and neck and the importance of posture. Now, posture in general is a very PT important thing to talk about, but I really want to focus on the alignment of the head and neck. So the picture all the way to hopefully everybody's screen looks the same. The one that says 12 pounds, all the way to my left. That's neutral alignment. So in neutral, that's where your head should be. Your ear should be over your shoulder, should be over your hip. Your head weighs about 12 pounds. The average human head weighs about 12 pounds. The one in the middle, that head is moved forward by about 2 inches. When you move your head forward by about 2 inches, you've now increased the weight of your head to 32 pounds, creating significantly more strain through the basin of the skull and the back of the neck. Going forward another inch to 3 inches puts it at 42 pounds. That's a significant change. That's adding, just from having bad slouched posture with your head forward, you've added 30 pounds onto your neck. So your neck is not a very strong structure. It's very tiny. Most people describe, when they have a Chiari and other craniocervical instability, they feel like they have a bowling ball resting on top of a bowling pin. Well, this is why. That bowling ball is going from 12 to 42 pounds if you have bad posture and you can't hold your head up. And if you can't hold your head up structurally, we need to help you as much as possible compensate for that with your postural muscles to allow the structure there to assist with that. But what's important is you look at the alignment of the head and neck when it's straight. When we talked about before, we treat the head and neck and we think of all the muscles and the joints there, but don't forget that the Chiari in this population is underneath that area. So if we look at the alignment right now, the head and neck, all the way with the 12 pound, look at how big that angle is. And so that's what a neutral head and neck angle should look like in general. But when your head goes forward, like we talked about, the eyes stay on the horizon line. So in order to do that, so that if you bring your head forward and you don't adjust anything, you're going to look at the ground. And everybody knows you're not going to walk around looking at the ground. So what you do is you tilt your head backward and you rotate it upwards so that your eyes are still looking straight. But look what that does to the angle of the head and the neck. it's really squashing that whole area. So you're already going to be causing a facilitated segment in that area because now you're pinching and squashing the nerves back there. But then on top of that, don't forget there's a Chiari in there. So if there's a Chiari in there and then you're already pinching it, so the average human being is going to have a horrible headache with that kind of posture because of the facilitated segments. And then you're already having squashed brain tissue, which you're now squashing further by holding your head in the bad position. So patients with Chiari are complicated, whether they have just plain Chiari or if they have Chiari and all of the other comorbid conditions that often go along with it, you tend to be a complicated patient population. So it's important to understand and recognize that a physical therapist is only going to deal with physical therapy related matters. They're only going to deal with the PT issues, and everything else is going to be dealt with the practitioner within their scope of practice, because we each have a role to play in that. It's important to remember that you are a very important member of the team, because I tell all of my patients, they often will come in complaining, and I tell them, I can't fix you. You're not broken. I can help you improve yourself, but you also have to be an active component of this, because I can't fix you. You have to be the one involved with your whole team acting together to move towards a recovery model. So general PT guidelines I wanted to go over. So I have a lot of people that call me up and say, I want an expert. I want a PT that's an expert in Chiari, or I want a PT that's an expert in EDS. You're not going to find one. There are very few of us out there that see this as very rare that the patient or the PT will see nothing but connective tissue and Chiari and tethered cord all day long. It's just not common. And then those who do see it, it's because you see it, and then you tell the patients talk to each other, and you get known as the expert in this, so everybody comes to you, and that's how I learned. So your best bet is to find somebody who's willing to learn with you the things that you're going to want to look for. You really need to focus on finding somebody that's going to give you individualized attention. Do not go to a clinic that has a factory. So when you call up a clinic for physical therapy, you want to go somewhere that they're not going to double book you. Don't go to somebody, if they're going to see 4 patients an hour, don't be one of those patients. You really need that one-on-one attention from somebody, because you're complicated, and the symptoms are complicated, and the treatments are complicated, and you can't be bounced around with other people as well. Like I said, you want to have that person have a lot of knowledge in manual therapy, because we found like significant success about patients that get manual therapy and structural alignment of the head and neck in terms of their Chiari. The other guideline that I like to tell people is, when I talk to other PTs, just as a general rule, low and slow. The lower and slower, the better. I tell a lot of people when they have 1 or 2 visits with me, and then they have to go to a PT somewhere else, and they have to find somebody. I tell them that you want to be treated like a little 85-year-old lady who has osteoporosis, and if you wouldn't expect them to do that exercise, don't expect me to do it. And every patient is different, so there are those patients that will be able to tolerate more, but don't expect that. Expect them to work with you to find out what you can do. And then, like I said, find somebody that you're willing and comfortable to be with, that's going to be willing to be with you on a journey, because it's not going to be a one-time PT session. It's going to be a journey. But PT is very specific to each person in each situation, so there is really no good general guideline that I can tell you of, oh, you always do this first, and then you always do this next. It's not the case. So how do you go about choosing a PT? Like I said, you want to find somebody that you're going to be willing to go on a journey with. And everybody thinks that they're going to find this lovely journey, and they're going to go on this nice bucolic walk down a beautiful road, and beware that your journey is going to look a lot more like this. It's going to be a lot of ups and downs, a lot of missing puzzle pieces, and you're going to have to find and really kind of help each other through that journey, and you're going to be lost along the way, and it's not going to be a straight path, that's for sure, but as long as you have somebody that's willing to go that journey with you, you're going to learn together, and you're going to have a better outcome. More importantly than how to choose a PT is to know when to lose the PT. So a lot of patients stay with the PT that they're with out of loyalty. They went to them when they had their knee surgery, and so they went back to them. It's not the same. And don't stay with somebody because you feel like you have to. Are your needs being met? Are they the right person? Every PT out there has to be good at something. And so, if somebody sees a lot of patients with ankle sprains and that's all they see all day, it doesn't mean that they don't know how to treat a knee, or how to treat the Chiari, but they're probably not going to be the person that you're going to want if all they see for the last 15 years has been an ankle sprain in a sports medicine clinic. That's not going to be, your needs aren't going to be met in that situation. If your PT has ever written in your notes or has ever told you that you are plateauing, run the other way. So I have, my mentor told me this years ago. I've never written it in my notes. I've never used it. Patients don't plateau. Therapists do. Doctors do. Patients never plateau. They don't just stop getting better. They don't try to stop getting better. If they're not getting better, we as the therapist, the clinician, we have plateaued. We have reached the end of what we can do for you, and that's when we need to refer you to somebody else. So if I have a patient that I'm not making successful gains with, I'll refer them to one of my colleagues. I do it all the time. Like, I just can't get anywhere with this person. I'm not helping them enough, and it's not that they're not getting better. I have stopped helping them get better. So you need to like change what you're doing, because if you keep doing it, they're not plateauing. You as the therapist are plateauing. If there's any issues with injury or safety, if you don't feel safe in that clinic, you need to leave and find somewhere that you do feel good. And then, is it the right fit for you? Sometimes I have patients, we all do. They could be the best therapist in the whole world, and you just don't like them. That's not the therapist for you. If you can't have a good relationship with them, it's going to be that long, arduous journey. It's not the quick fix. If you can't get along with that therapist and they're just not working well with you, find somebody else. They might not have as much experience, but you get along with them better and they're willing to work with you, go with them instead. So I did see a lot of questions come in, so that is the end of what I wanted to kind of cover, and I would love to go over more, but I figured I'd leave it at that and just tailor it to all the questions. So.
Perfect. Thank you so much. That was an amazing presentation. Thanks, Dr. Meegan. I'm going to start with some of the questions that came in the chat. One that just came in is really, really good. In general, are there particular symptoms or conditions that make someone with Chiari likely to benefit from physical therapy specifically? Or is there any way that you would know?
Or conditions?
Mm-hmm.
So somebody that has, so I'll go back to the symptoms of Chiari in general. Sorry, I'm not very good with technology.
Me either. Sorry.
Hold on, where is it? There we go. So a lot of times when I get patients that don't know that they have a Chiari, a lot of times it's the headache and the neck pain and the muscle weakness and like the brain fog that they're coming in complaining of. So the reason that I had put this slide in there is these are all symptoms of other conditions, but these are all things that PTs treat, except for dysphagia, a speech therapy thing specifically. But these are all things that are different modalities can be used within PT to treat. So anybody with Chiari symptoms that has weakness in the arms, numbness and tingling in the arms, and headache and neck pain, those are going to be highly susceptible to improvements with standard PT and standard PT kind of treatments, even if it's somebody that doesn't know that they have a Chiari. Those things will improve with PT.
Okay. Similar to that, another question that came up, they're talking about Chiari malformation and craniocervical instability. They can have a lot of the same symptoms, but is treatment in physical therapy for those conditions different? Do you do different things with Chiari versus CCI patients, or is it the same? Why or why not?
Yeah, so it's, in general, it's the same. So if I have a patient that has Chiari but doesn't have any instability, I would do the same treatment I would do with a patient who has instability but doesn't have a Chiari. And I would do the same treatment if they had both. I would be very cautious and modify a lot of what I was doing. If somebody had cranial cervical instability, you're much more cautious with your adjustments. I do less mechanical adjustments there and much more fascial work and let it be softer adjustment. I don't perform any manipulations on head and neck, period, just because my whole patient population is contraindicated for it. So I'm a lot gentler with patients with CCI and more focus when you have CCI. More focus should be placed on proper head and neck alignment and strengthening in that alignment versus Chiari. If you don't have instability, the strengthening, unless you have weakness from the Chiari, the strengthening isn't as important as relieving the symptoms.
Okay. A question from earlier before we got on today. There was, I think you started to sort of discuss it, but how can physical therapy help with things like balance or with like dysphagia or speaking? That you said something about speech therapy and stuff like that. Can PT help with those things too?
Sure. It depends. Yes, PT can help if somebody is trained in manual therapy. So PT in general isn't going to help with dysphagia. The standard treatments like that won't. But just like with the back of the neck, which is pretty much all people think PTs can treat, the front of the neck and the throat, those are all muscles and joints as well. And the mechanics there respond very well to manual therapy. But if there is an issue very specifically with dysphagia and difficulty swallowing, you do want to also employ a speech therapist because the swallowing component of it isn't PT, but dysfunctions of the hyoid bone, which is this floating bone in the front of your throat, it's not connected to anything. It's just connected to a bunch of muscles. So if it's imbalanced or subluxed or moved to the side, it's going to create spasms and tightness, which can cause dysphagia, which is common. So sometimes if you correct that, it lessens the symptom, and then you can alleviate which one is the symptom from the Chiari and which one is the symptom from the compensation of the neck.
That's interesting. And then one more question about this that came in earlier. You sort of discussed it. You talked about brain fog. Have you seen manual physical therapy help with issues like fatigue or brain fog that are kind of harder to distinctly connect to Chiari or CCI because it could be from so many other things?
Yes. So one, I would say 100%, and I don't care where it's coming from. That's not my job. So if you have brain fog and it's from a Chiari or if it's from POTS or who knows what it's from, it will get better. A lot of times brain fog comes in the average patient population, no Chiari or anything. If you sit, everybody there, let me clarify. If this is unsafe for you, don't do it. If you have instability and you're currently symptomatic, don't do this. But everybody just kind of slouch for a second and let your head hang and let the back of your neck really, you bring your head forward. You'll feel the back of your neck kind of cramp. If you sit there for a second, you'll notice that things just feel funny. So like as I tilt my head back, it just like you can feel a pressure build, but if you sit up straight and then kind of stretch your ears up towards the ceiling, everything becomes a little bit more clear. So what just happened is that the basin of your skull is where all of the cerebral spinal fluid sits, and when you cramp that area down, it blocks it. So the fourth ventricle gets blocked with Chiari, and so you don't get a good circulation of that cerebral spinal fluid flow, which is the nutrient that bathes the brain, but it also cuts off a lot of the blood flow at the base of the brain. So if you can align that properly, you're going to relieve those symptoms. So I would say most of my patients come in with brain fog on a daily basis and they leave without it.
Oh, wow. Yeah, but that makes sense for sure. One question that came in on the chat was your thoughts on prolotherapy, which I actually, to be honest with you, didn't know what it was, so I had to look it up. But when you inject an irritant into an injured tissue and it theoretically would stimulate growth factors to repair it. I don't know if you do things like that, if you know if that's similar to PT, if it's better or if not. Okay.
So prolotherapy is a specific type of therapy. It's not performed by PTs. As far as I know, no state has a license to do it. It's also different than dry needling. So dry needling is accepted in some states for PTs, not all. And in this population, I would never do it. I would never recommend any of my patients under my care get dry needling to their head or neck with Chiari. I can't speak to other people's opinions. That's my license and my opinion on my patients. Prolotherapy is when typically it's a dextrose or sugar solution that they inject. And what they're doing is they create an injection into the muscle and the fascial tissue. And the sugar solution and the irritant create an inflammation reaction. And then because of the inflammation, it creates stability because it creates swelling and scarring. I've had patients do it successfully, and I've had patients do it unsuccessfully. I will tell you that I have had a couple of patients that did it before they came to see me, or even after, that did it for the head and neck, and it's a lot of injections. I think that one patient that had it done before they came to see me, I think she had upwards of like 75 to 100 injections in the head and neck area. Smaller joints, you have less injections. I've seen it work really well with other areas of the body, with peripheral joints, but I'm not an expert in it. There's a couple of doctors in our Boston area that are, that have had really good success. I can share their info later. I know that the other people in the country do it, but I only deal with one or two around here that do.
Yeah.
But it is not the same thing.
Right. A question came up in the chat. I don't know what this is either, so I'm going to hope that you do. Radio frequency ablation for CCI pain. Is that something that you've heard of, or?
Yep, it's something I've heard of. It's also not a PT treatment. Somebody else in this chat could probably answer it better than I could, but I won't put them on the spot because I know that they are involved in doing it. The radio frequency ablation is performed by pain medicine specialists. Basically, they go in and they use different frequencies to sever some of the nerves that are causing pain at the base and at the back of the neck, through the pain signals that come out. I have had patients that I had 3 patients that had it done successfully before I saw them.
Okay. I want to get to some of the questions that came in prior. This is a good question. This is before surgery, so we're just talking about managing symptoms. Is head and neck manual therapy possible for a person with a retroflexed odontoid? So specifically in someone who has EDS and CCI.
Yeah.
Yes, that was a good one. And then what are your thoughts on cervical traction for patients with CCI and Chiari? Is that something that is done in PT, or is it just like just the brace?
Yeah. So to be clear, the answer is different between different patients and different patient populations. So somebody that has cranial cervical instability, they probably also have a connective tissue disorder. I don't tend to traction, so connective tissues do better. They crave traction on those joints because they're seeking proprioception. So that's why most people feel much better when they pull on something. But when you do that, you run the risk of potentially injuring that area. So some protocols from some surgeons require you to undergo upwards of 20 pounds of pressure, and a lot of PTs will use a mechanical traction unit. I don't. I've worked with a couple of different neurosurgeons. They all have different protocols, so it's more of a surgeon-specific question. It is definitely a PT treatment. I always provide manual traction because, like we talked about with the nail, if you think about that with your head and neck, if your head and neck aren't aligned properly, and so hopefully everybody can see me. If I walk in like this and I put my patient in a traction unit and it tractions me, but I'm crooked, it's going to traction me crooked. It's going to traction one side more than the other. Whereas if I do it mechanically with my hands, I can adjust the alignment as I'm going, and I can pull a little bit harder on one side, a little bit easier on the other until I get a good neutral traction force. And I always start much, much lower and work my way up. And I did see, I'll also just answer the other question that came in earlier. I also don't do it quickly. I do it very slowly, and I start very slow and do it one day a little bit and see if the symptoms are alleviated and kind of gauge, all right, these symptoms are alleviated at this versus I just go straight for that pulling at 20%, because the other thing, think of it like a slingshot or in a rubber band. If you pull something and then you let go, it recoils and it snaps back. That also happens with traction. So it is common when you provide traction, especially if they're symptomatic. But if they're symptomatic, they can be more symptomatic when you're done, because now you've alleviated those symptoms. They feel great, and then you recoil, and all of that links back together, and that is common. So if you're having that happen, you need to go slower. And if they're doing mechanical, request manual and see if that helps.
Okay. This is a good question from the chat. Can you use craniocervical therapy on someone who's known to be susceptible to CSF leaks? Am I speaking right? Yeah.
Can you use what?
Craniocervical therapy on someone known to be susceptible to CSF leak.
Yes. The caveat to that, again, like I said, this is one area where it's a bit of a pet peeve. Craniosacral therapy is not regulated by anything. There are lots of courses out there that you can take a 1 weekend course and call yourself a craniosacral therapist. You can be a massage therapist. You can be an accountant, and you can go to this course and call yourself a craniosacral therapist. So all craniosacral therapists are not created equal. I don't call myself a craniosacral therapist. I practice manual therapy. I would say craniosacral therapy is maybe 10% of the techniques that I do. And I have them on patients with CSF leaks during an active leak. And if you do the techniques correctly, you can alleviate the symptoms. But if you do the techniques wrong, you can exacerbate them. So you really have to know what level kind of practitioner you're dealing with. And if you're susceptible to CSF leaks, don't deal with anybody that's not a master level or below.
Yeah. Okay. And I'm sorry I didn't do this earlier, but you kind of discussed this. I just want to make sure that I understood it. Someone had written in saying that they initially experienced improvements in symptoms during and right after cervical traction, but then they developed severely worsening symptoms for about a day that can be pretty debilitating. And they were surprised by this because they were asked to do this in preparation for a neurosurgical appointment. They say something about delayed rebound effect. Is that what you were describing, or is that something different?
Yeah, so that there is that while you're in the traction and right away you feel great, and then you can have a rebound later. That is common. So recording the fact that you felt better while the traction was there, that's the result that the neurosurgeon's looking for. But be aware that you probably will have rebound effect afterwards.
Do you know about how long that might last for, or is there like a range? No.
Every patient's dependent. Most of the time with my patients, if they have rebound, I try not to let them get to a rebound point, but I've had patients that have had rebounds. It's usually been 2 days. Okay. But everybody's different.
Yeah. So sort of to this, there have been a couple of questions about basically like longer term recommendations for PT specifically. So say there hasn't been surgery yet. One person had written in before and someone asked about long-term recommendations for PT. Are there any programs or specific exercises that are helpful to manage symptoms while maybe someone's waiting for a consult or just to go through surgery? In context, the person that had written in earlier has CCI and an abnormal curvature of the spine, so it was a little straighter. Yeah. But are there specific things that people can do to manage symptoms?
Yeah, pretty much. I would say specifically, but also a long-term general thing. You can never go wrong with neutral posture exercises. So anything that brings you to neutral posture is always going to be beneficial. You're not pretty much ever going to have a contraindication to aligning yourself towards a normal recovery. There are instances where you're not going to want to do strengthening per se in standard kind of PT exercises. You want to back off and do more isometric, gentle things that don't move you. If you have a lot of instability, you're going to want to strengthen the muscle but not move the joint. But if you're always attempting to bring yourself to neutral in your posture, that's where the body understands how to function. that's going to be your best. So if you work on anything that's going to improve your core stability, so if your head and neck and your Chiari symptoms are too severe to even work on that area, you really want to focus on your abdominal, your low abdominal, your pelvic muscles, your hip muscles, because the stronger that you make your base, the stronger that everything can stack up on top of it. So if you can't even work on that area and it's too symptomatic, work on everything else around it, and it'll help build up the strengthening of that foundation.
This is a really specific question. How long after surgery, so decompression specifically, can someone start doing exercises? For instance, should someone wait until like the wound heals up until you do any neck exercises? Yeah.
No, there's no specific answer. You said how long until they can start strengthening exercises?
Yeah.
Again, you can start postural strengthening exercises from day one. You don't want to start anything that's going to potentially cause ripping, tearing, or tension around the wound. So you don't want to even start isometric or neck exercises for a week or a couple of weeks afterwards. I've seen patients with Chiari decompression. I've seen a couple of people within 1 week of post-op because they were here. So I get them directly from the hospital admission a lot of times. But I'll work on postural strengthening to like the thoracic spine to hold the rib cage and the head up and the core stability, but I won't start neck stuff until the wound is healed. And at least that 2-week post-op, when they go back to that wound check, I won't touch anybody.
Mm-hmm. So, but you can start with like the core, like you were saying.
Yep,
really.
You can always start with core. There's pretty much no reason to ever avoid doing core stability in this specific instance. But you can do manual work. If the PT is trained and knowledgeable, I personally will start treatment on post-op Chiaris right away to prevent the adhesion of scar tissues and prevent abnormal mechanics from starting to form from compensations. But I don't do any. I do everything very, very slow and always in neutral. And pretty much I have them come in if they have instability as well with those Chiari. They come in the brace. We take the brace off once they're on the table. I treat them. We put the brace back on, and we let them go. We don't have them walking around immediately post-op without their bracing and stuff like that.
A really good question just came in. How does one work the abdominal muscles if you're not lying on your back or you're not straining? You're not allowed to strain. And separately, would electrics, so stim devices, help creating muscle tension without having to move back much? Like, how do you do those ab work?
So, everybody that knows me knows I'm not a huge proponent of electrical modalities, but there's a couple of commercials out there right now of if you stick these stim machine pads on you and it'll give you a six-pack. It's not how that works. So that is not a good option. I have seen PTs do that for people. That is not a legitimate scientific thing to do. So there's an exercise that pretty much every PT will teach you. It's called pelvic neutral. The easiest way to learn it is lying down, but you should be able to perform, every human should be able to perform pelvic neutral and contraction of those core muscles in supine or lying down, sitting, standing, or anytime that you're moving through space. So if you can't sit down, if you can't lie down because of whatever reason and you can only sit, you can still perform those exercises, and pelvic floor Kegel exercises and lower abdominal bracing exercises can be performed in any position. A lot of times I do actually have patients post-op because of other complications with CSF pressures. They're up on an incline anyway, so they're not always lying down, and they can still perform a lot of those exercises.
Okay. And then you had said that you don't recommend dry needling, correct? In these patients specifically, or I can't remember.
In this patient population specifically, more so with Chiari, but also a lot of times because Chiari also is often overlapped with a lot of the comorbid conditions and connective tissue issues. Dry needling in this region would, in my opinion, I wouldn't do it. I would not allow it, but I've had patients do dry needling to other areas and it's fine. But I wouldn't do dry needling to this area. I just think there's too many important structures up here and there's not enough good science behind the dry needling process or what happened in this patient population.
And to clarify two things on that, what about the thoracic spine? And then does that also apply to acupuncture? Is that a different thing?
Acupuncture is different. I'm not an acupuncturist, so I have patients that do it and have had great success with it. I've never had any negative reactions with the acupuncture, but I can't speak specifically on it. And yes, again, I don't do dry needling, so I can't speak on dry needling outcomes. It's a very relatively new thing to do, but you're much safer to have it done in the thoracic spine. Dry needling pretty much will target trigger points in those muscle spasms, and that that is much safer. The thoracic spine is much more stable. The person that just asked that question, to go back on it, so like I said, you can still do things in standing. That list that you can still do things in standing for pelvic neutral, and you can do pelvic neutral standing up against a wall if you can't sit.
Mm-hmm. So before I move on, do you also see any hypertonicity in pelvic floor in this population, or is that more like a tethered cord thing? Or
it's definitely related more to tethered cord than Chiari. I wouldn't say that pelvic floor hypertonicity is a Chiari symptom. It's a comorbid symptom because, like we talked about, the tentorum, which is that part of the brain that holds the one that's horizontal. There's 4 diaphragms in the body. One of them is the tentorum in your brain. Then there's the thoracic outlet, which is a diaphragm in your body. The one that everybody understands and knows about, the breathing diaphragm in the middle. And then your pelvic floor is actually a diaphragm. So when one of them is off balance, they'll try and compensate for each other. So if your diaphragm that you're breathing with, or your thoracic outlet, is hypertonous from postural instability, joint instability, or some other reason, you're also likely to have pelvic floor hypertonicity. So if your tentorum is off, it can cause that, but I wouldn't say it's a direct correlation. It's a compensatory thing, but I wouldn't say that I don't do pelvic floor internally, so that you would want to go to a pelvic floor therapist, but it's not contraindicated to do that as well as have Chiari treatment.
Yeah. Are there any specific types of exercises that should be or should not be done after decompression or after a spinal fusion or anything like that?
Well, that's 2 different questions. So decompression. So after a fusion, you should not try to do a lot of range of motion exercises because you don't want motion. You just use it. And so you want to avoid a lot of motion there. Pretty much always isometric strengthening, which is strengthening that occurs in a muscle when the joint doesn't have to move, is always indicated as the first step in when you're strengthening something, whether it's postural or anything else. Trying to strengthen the muscle without moving the joint to create more motion is always going to be important. So you can do isometric strengthening for the head and neck, and then postural strengthening for the postural strengthening for the head and neck. Most of the time, your best bet is to actually target the shoulder blades. If you target the shoulder blades and hold the shoulder blades back, the attachments of the shoulder blades go up into the basin of the skull. And so if your shoulder blades aren't stabilized properly down onto your rib cage, they're going to cause spasm and pulling up the basin of your skull to the back of your neck where the Chiari is. And so that alone will cause you to be symptomatic.
Okay. Yeah. This whole conversation is giving me such a headache, but I have to sit up straight. So we actually received a question from someone who's a little bit more remote. They're in a village, and they have limited access right now to PTs because of COVID. They're not able to get there, and I'm sure similar limits exist for a lot of other patients. They can't always access PT. Is there anything that can be done, I guess, not under the direct care of a PT that might help, or is that just going to make it a little bit more messy? I mean,
I read that question earlier. I would say in that specific kind of a situation, that's when I would defer to saying I can't answer that question because there's so many other comorbid or potential issues that could be that I tell you that this is a generally safe thing for everybody to do, but this patient has, a pacemaker that misfires every. So I would say because of COVID, we actually they changed a lot of the legal rules, so we can now start to see patients through telehealth. So we've been doing evaluations and even just consults in the U.S. with telehealth. I know Rhode Island is doing them. I've done them through every region of the country now at this point. I don't know how they work internationally. I don't know whether you're allowed to do that because I haven't had any yet. But I know that if we're doing it, that also must exist. But I would say have them call in and we can look it up. But I would say set up some sort of at least consult with a PT to go through your medical history, and then they can give you something. But not knowing anything about this patient at all, I would definitely not hazard to guess what to tell them, other than work on your posture. That's a pretty safe bet for everybody.
yeah, no, and I kind of defer to that too because I know even when I'm doing something very simple at the gym, if you're not doing it with the proper form, you can definitely do way more damage than
Yeah.
without. Yeah.
And like I said, a lot of my, everything I do, none of my patients are textbook, and none of my patients fit in a cookie cutter model. So I don't have a protocol that I follow. I have some patients that can barely do level 1 of some exercise, but I let them jump on a BOSU because that's not contraindicated for them, but they can't lift a 1-pound weight.
Right.
But, so it depends. Each person's different. They could have really debilitating things changing positions, so they can't, their dysautonomia is really severe, so like they couldn't do something that would be in a certain position that would be considered easier, and I wouldn't want somebody to give advice, any PT. I wouldn't want anybody to give you advice that would potentially cause you to feel worse. So setting up some sort of consult, even if it's just a discussion before you go about something, you always want to seek the professional help first.
For sure.
Yes, wherever you are.
Yeah. So I'm going to kind of like go into this next question. So this came in the chat earlier. What type of clinic would someone have the best chance of finding a Chiari or a CC, someone capable of treating these things like you were talking about before? Is it orthopedics, sports medicine, specifically neuro?
So ironically enough, I work in a clinic, and part of our name is sports medicine. As a general rule, avoid sports medicine clinics. That's going to be the kind of orthopedic and sports medicine clinics are going to be the ones where you're going to get booked 4 or 5 patients an hour because that's the patient population that they see. Neuro would be good. But you really want to look for any sort of clinic. If you start to look in the area and just look on all their websites. Orthopedic clinics are great if they have PTs that know manual therapy. So an orthopedic outpatient setting is actually going to be where you're probably going to find the person that's going to help you the most, because they're going to have the skill set that's going to help you, but you're not going to realize it until you go on the website. So take all the words that I gave you in terms of manual therapy. They should list those as treatments on their website. Also look for the words holistic, like healing, anything like that. You're going to be at a better setting than somebody that offers, if they have a lot of pictures of gym equipment and like athletes, they're probably not going to be the right setting because you want a private treatment area. You don't want to be treated out in an open gym area with like 5 other people next to you. It's just not relaxing. But if it's so a lot of times neuro-based PT clinics gear more of their treatments towards post-rehab facility treatments, so patients that have strokes or patients that have just had brain injuries, and so they're more still in this functional model of recovery, compensating for, I don't know how to walk yet, so we're going to work on using a gait trainer and things like that and regain those functions. They're not going to be working on a lot of structural things, so they're probably not going to have a lot of skill with manual therapy in those specific neuro settings.
Right. I actually had a question. So you talked about the forward head posture. So Can that forward head posture, I know you say it happens in Chiari's often, or it can.
It happens.
I'm sorry?
It happens in everybody.
Yeah, I know because I was sitting here and I felt it. But can something like a forward head posture affect, so the measurements maybe on an MRI, so like a clivo-axial angle, I can't speak today. Do you think that that's possible, or because I'm genuinely curious, I'm just not sure.
Uh, Probably.
Yeah.
I defer to Dr. Henderson and one of the
Yeah.
surgeons. I would say possibly. The angles that they're measuring with the clivo-axial angles are more internal, but the forward head posture, the angle that's going to change is more the lower cervical spine. You're not going to get a lot of, so that would be more, that angle would change more if you had shearing of the skull on the neck versus the whole head and neck going forward, because that's going to rotate the head back, which would probably change the angle. But it would I actually, I can almost definitively say it will, because I've had patients once getting treated. I know I've had a bunch of patients that I worked with Dr. Henderson, and their angles improved after therapy. So yes, I would say I wouldn't say that it got worse because they had forward head posture, but somehow I was able to reduce the angle. So therefore, yes, it must have been possible.
Oh, that's cool. So I guess another question though is, have you seen in patients that may have come to you first, so they're trying conservative management versus surgery, have you seen symptoms improve to the point where maybe surgery isn't necessary or it can be put off for a certain amount of time? Is that, and obviously every patient's different, but is it common or?
Yeah. So uh, yes, it's common. So it's I've had it happen both ways. I've had a bunch of surgeons send me patients as a precursor of try PT with Trish. If she can't help you in the first, whenever she feels like she can't help you, then we'll go with surgery. But if you're making progress, stay with her. I have had everybody from, I've had a teenager that we pushed off all through high school, and she didn't have to have surgery until after she graduated. So she was able to make it through high school. And then I've had a couple that I've tried within, I've treated, and within a month I've called the surgeon back and said, I'm not going to be able to help them long term. You really should do the surgery now. What I'm doing is helping, but not enough that it wouldn't be surgically warranted.
Right.
So yes, it is possible. And then I've had patients that we were actually able to reduce all of their symptoms. I had a couple of patients that all of their symptoms were completely alleviated and reduced with PT, and then they got into a car accident, and then all of their Chiari symptoms got significantly worse to the point where we couldn't correct them with PT, and then they needed surgery. But it was because of the trauma that exacerbated everything, but symptoms could have been reduced prior to that.
Wow, that's really great. And then one more question before I address these two, because they're going to be good like wrap ups. Actually, I'll do this one first. So, do you think something like an upright posture trainer could improve these symptoms and reverse that forward head angle? Or is it just the strengthening of the core? How would you do that?
So yes and no. Upright. So I'm assuming that they're talking about posture, bracing, so there's a bunch of different trainers out there. There's some that buzz you to tell you to sit up straight, and then there's actual braces that you put on that help align you and hold you up. If you're using the postural corrector as a training modality, then yes. If you're using the postural corrector as a brace, then you're actually going to have the opposite effect. So if you're trying to use a posture corrector or a posture trainer to help hold you up, the brace is doing the work, you're not. So your body will actually revert back, and it'll start to cheat and say, well, the brace is doing the work, I don't need to help hold it up. So you don't have to use that. So if you were to put an example, if you were to put a cast on somebody's foot and then just leave it there, the muscles inside that cast aren't working, so they're going to atrophy. So if you just use the brace as a brace, the muscles will start to atrophy and get weaker because you're wearing it. But if you're using it to help you correct the posture and give you a cueing, like a proprioceptive cueing while you're doing it, and try to wean yourself in and out of the brace, then yes, it will definitely help correct it.
Okay. So these are all going to be sort of related. So first of all, how does one know if their PT has plateaued for them? So how do they know that this isn't working anymore and it's time to find a new
Ask
clinician?
them.
Ask them.
So when I wrote the word plateaued, if the PT has written that about you, they have already plateaued. If they have already blamed you as the patient for not getting better, run the other way. And sometimes it's a discussion both ways of, maybe it's you tell them things aren't working and they say, okay, let's try something else that we haven't tried, and maybe they haven't tried something. Ask them to pull another trick out of their bag. If it's something where they keep doing the same thing and they genuinely think that they're helping you and you don't feel that they are, have that open discussion with them and say, like, I'm just not feeling better. Is there anything else we can try, or should I go somewhere else? Or is there anybody else that you can recommend that I see? Just like with anything, like it just might not be the right fit, or they might have gotten you to that point. Just like coaches with, athletes, they could be the best coach in the world and they can only get you so far to a certain level, and then you need a different coach to bring you to that next level. It could be the same thing with PT. They were a great PT. You have nothing against them, and they got you as far as they could. They got you from something very debilitated to where you are, and they just can't bring you that last bit. That's when you need to refer out to somebody else. I myself, like I said, I refer out all the time. I still refer to the people that trained me. I send patients over there all the time saying, I'm missing something. Like I'm stuck on this thing. We're not getting better. I shipped them off to the other clinic that I worked in and I trained in, and I said, even if it's just one visit, like, please see this patient and see if you see something that I don't, that I can do. Like, it might be something that I can do for them and I just don't see it. And so I'll refer to other people saying, like, what else do you see? And then I can fix it. But if I'm not seeing it and I'm not helping you, then you gotta leave me too.
Yeah. Yeah. To that, so do you have any recommendation about how so obviously telehealth has made this great because you can see people who might be miles and miles away, but is there any recommendation that you have other than finding those things that they list on their website, about how to find someone nearby? I genuinely, I don't even know how to find a local PT that I would trust necessarily.
So we should be a lot better at it. We are terrible as a profession for doing this, but I think the medical profession is terrible at this. However, again, there was a disclaimer on this. I can tell you because I know it. So I'm on the board for Dysautonomia Support Network, and we have in our setup a physician locator, clinician locator, provider map that tells you where you are in the country, and it'll list all the providers, and they're typically taken from patients that have already had successful outcomes with those people. So if you recommend that your PT is really good, you can recommend that they get put on this list, and then that list shows up. So you can search them through there. I know that other organizations might have something similar to that. Word of mouth is a lot of times the best. That's how most patients find me. I don't know how people find me half the time. It's like, oh, I found you through so and so and so and so and so and so. But yeah, I would say when I do patients, when I treat patients with telehealth and I'm trying to help them, or if patients a lot of times I have patients that come to see me for 1 week to a couple of months, and they'll come in for like short rehab stints. Then we try to set them up with somebody back home. I'll go on just Google and I'll look in their area, and I'll Google all the PT clinics in their area, and I'll just look at their websites, and I can pretty much tell just from looking at them whether I'm going to like that clinic or not based on how they design their website and what they put on it. And so I do a general geographic search and then do that. But a lot of times you want to widen your search, because sometimes if you're just looking in that little area, most of my patients I would say half of my patients drive an hour and a half to 2 hours to get to me. And we're a very close populated area. They probably pass through like 30 different PT clinics, whereas in the rural areas, you're going to be looking at potentially a 2-hour commute just to find a decent clinic anyway. But I would say go to the Dysautonomia Support Network, go to that website. We have a provider map on there that'll give you some general ideas. And then the other best thing to do is talk to the patients in the different chat groups. I know the Chiari chat groups and EDS chat groups. Check with them and ask who they see and ask if they like them. Because that's the other question is they might be seeing somebody, but they might not like them. So ask them for their opinion on whether they would recommend the person they're seeing.
Yeah, and I know we have support group meetings every month. Mary knows more about it than I do, admittedly, but so people can join those too and probably ask for the word of mouth, like you were saying.
Yeah.
But so to that effect, though, if someone wanted to come see you, do you treat adults only, or do you also see pediatric patients? And then B, how would someone get in touch with you, set up a consult?
So yes, I actually have an infant right now. So I treat infants all the way up through the whole lifespan. And so our company, we have 4 different clinics, but my specific location, I'm in our East Greenwich location. So the number is 401. I'm reading it off of a pen because I don't remember it all the time. 401-471-7510. And I work for Healy Physical Therapy, and you can go online, but I would say call the office and you set up an evaluation appointment consultation. The office manager is wonderful. She'll take all your info and kind of help you through the process of what you need to know. And they can help you figure that out. I do treat pediatrics all the way through, the whole spectrum of life through, and I see anything that walks in the door.
That's great. I'm going to squeeze in one last question just because I'm interested. Yeah. Is there a really big difference in the PT for, I guess there is, for an infant, pediatric, teens maybe, and adults?
Yes. So in terms of this lecture, no. So if you're treating somebody, if you're treating with a manual therapist will be able to have the skills to treat infants through, because it's the same type. But a pediatric, so yes, pediatric therapists also come in many shapes and sizes. There's school-based pediatrics, clinic-based pediatrics, and so a lot of them are play-based and developmentally based. That wouldn't be what you're looking for, versus somebody that for pediatrics, for Chiari, you don't want to go to a pediatric therapist because that, like I said, is going to be more pediatric problems, versus you really want to find somebody that's a manual therapist. And you find somebody that's a manual therapist, they will be able to treat pediatrics.
Okay, so even if you are a pediatric, you're still looking for manual therapy in that sense.
I would still look for an outpatient manual therapist, yeah, because the types of treatments you're going to be provided are, you don't want to be in a gym setting with other kids running around doing balance exercises and developmental exercises. That's not the kind of treatment that's going to benefit you the most.
Right. Very
valid. Pediatric therapists are wonderful. I've worked in these clinics, but not the type of treatment for this patient population.
Perfect. Okay. I think that's it. That was like an amazing, and see, this was so informative. I agree. This was a really great talk. We don't have a lot like this, and honestly, this is so important because when a patient finishes at the neurosurgeon, I mean, if they're still having issues, they have to see you, So this is great. Thank you so much, Dr. Meegan, and thanks everyone for.
Thank you for inviting me.
Anytime.